Okay, I guess we'll get started. Good afternoon, everyone. I'm Manjot Gill from the Department of Ophthalmology, and I'm currently serving as Vice President of the Medical Faculty Council. I'll tell you a little bit about what the Medical Faculty Council is. We are the body that represents the faculty of the Feinberg School of Medicine here at Northwestern and serve as a liaison between Feinberg faculty and medical school administration, and are really a platform for faculty to voice their concerns and offer feedback on matters related to the medical school. The mission of the MFC is to foster a culture of academic excellence by promoting transparency, collaboration, communication, and mentorship within the Feinberg community. Each year, we sponsor 2 IFAM lectures that serve to highlight the class collaboration that occurs between multiple disciplines in the School of Medicine in order to advance the care of our patients. Today's lecture by Dr. Seema is no exception and is a wonderful example of that. So I will turn it over to my co-chair, Dr. Daniela Ladner, Professor of Surgery, who will introduce our wonderful speaker today.
Hello, everybody. I want to extend a warm welcome to Dr. Seema Khan. She's a professor of surgery and the Bloom Family Professor of Cancer Research. Dr. Khan is a clinically active breast surgeon and one of the most highly NIH-funded surgeon scientists with over $4 million in annual funding. Those grants include P grants, T grants, U grants, and R grants. Dr. Khan is a first-generation immigrant, did her medical school at the Dow Medical College in Pakistan, and trained in the US surgery at St. Agnes Hospital in Baltimore, and did her fellowship in breast surgery at the Roswell Park Comprehensive Transplant Center, Buffalo in New York, and then got an MS degree from the Harvard School of Public Health. She's a member of many prestigious societies, including the American Surgical Association, American Association for Cancer Research, and she chairs multiple national committees, including serving as the chair of the Cancer Prevention Clinical Trials Network Steering Committee. Please welcome Dr. Khan as the invited lecturer sponsored jointly by IFAM and MFC. It's a weekly seminar series every Thursday, and there's going to be some more information in the chat. For this discussion, please use the Q&A for questions, as Dr. Gill will ask all these questions at the end of the presentation. Welcome, Dr. Khan.
Thank you very much, Dr. Ladner and Dr. Gill, for inviting me to present to this group that I actually have been wanting to connect with more. So hopefully this will be a good beginning. And I'm certainly very happy to be here and tell you about what I have been engaged in over the last 10 to 15 years, which has been, as I say in my title, a long and winding road to which I do not yet see the end, but it's a journey to talk about anyway. So the title was cancer prevention with drugs, and I guess the first question, particularly in a population science group, is why bother with drugs? Because there's so many available strategies to reduce risk of cancer in general, and also reduce risk of breast cancer. So there are interventions that relate to diet and exercise and weight control and all of those things that obviously are good not just for cancer risk reduction, but for risk reduction for many different organ systems. But there's also this issue of supplementation that's been knocking around for a long time. And I just chose 2 examples of very large, ambitious trials that were undertaken based on excellent epidemiological data, very strong evidence that these interventions would work to reduce lung cancer risk in smokers, beta-carotene in smokers, and then selenium in prostate cancer and a variety of other cancers. And these were, sort of really lead balloons. They were very disappointing results. And similar results, I mean, there haven't been any other trials that were this large in scope and ambition, but many other trials using these kinds of interventions also have not led to positive results, implementable findings. So we have to turn, I think, to drugs, because drugs are known to work in certain cancers. So just to finish up this issue of supplements, this is a Cochrane review from a year or two ago. And I actually was not aware of the extent of the disappointment in sort of vitamin supplementation and at least lung cancer risk reduction. So these reviewers who conducted the analysis for the Cochrane group, their conclusion was that there is no beneficial effect of supplements for the prevention of lung cancer and lung cancer mortality in healthy people. Vitamin A supplements actually increase lung cancer risk. We saw that in the carrot trial, the beta carotene trial. And vitamin C increases lung cancer incidence in women, and vitamin E increases the risk of hemorrhagic stroke. So supplementation, and there are similar stories about supplementation with extracts from soy and green tea and a variety of other agents, some of which are still, those investigations are still ongoing, but this has been a generally disappointing area. So in breast cancer and also in other areas, particularly prostate cancer, the idea, because there are endocrine agents available that are relatively well tolerated, in the 90s, there was a lot of discussion about if a drug works for cancer treatment, it should work for prevention. And of course, there are caveats. It has to be safe and well tolerated. Then looking at the results of treatment trials, there were clear preliminary data that estrogen receptor modulators such as tamoxifen and anti-estrogen agents, aromatase inhibitors in treatment trials made a substantial difference in the risk of contralateral breast cancer. So that was the model, the contralateral breast, and the frequency of cancer in the opposite breast really declined significantly, about half, in women who were taking these drugs for treatment of a cancer in one breast. So the fact that these drugs had much better tolerability than chemotherapeutic agents sort of led to the idea that they were tolerable enough and safe enough to use in prevention. So taking these drugs to the prevention arena, the same doses and treatment durations were applied. And that is an idea that is being very actively revised at the moment, with the realization that the doses and treatments that are necessary for the doses and durations that are necessary for treatment are not necessarily applicable to prevention. So just as a reminder, this is the first large-scale prevention trial in breast cancer, the NSABP P1 trial that tested tamoxifen 20 milligrams daily against placebo, and it was in fact halted early. It had a accrual goal of 16,000, but it was halted at 13,500 because of these positive results. So a 50% reduction in the risk of new invasive or non-invasive breast cancer. So there was a big, great welcoming of these results, with the idea that we could now make a serious dent in the incidence of new cancers in high-risk populations. So the women who were enrolled to this trial were considered to be at increased risk of developing breast cancer, and in that population, tamoxifen seemed to be a really good option. And then once the equivalence or even the superiority of aromatase inhibitors was demonstrated in the treatment arena, these were also tested in the prevention arena. And these are results of the IBIS-2 trial, which had a prevention arm. And in that, So here you can see that the solid lines are the placebo group with invasive or non-invasive cancer. So this is the placebo group and the anastrozole group, and both the incidence of invasive and non-invasive disease decreased very substantially, about 1/2 with the use of these agents, but again being used at the same with the same regimen as applied to treatment. And then, you know, obviously there were with these large populations and the fact that these were healthy women, the realization, you know, became apparent that the toxicity that we thought was really fairly minimal in a cancer treatment population was not so minimal for healthy people. So in trying to move forward from these classical trials to aspects to regimens that might be more tolerated, the area that has been used, the model that has been used very frequently is ductal in situ. So this is a non-obligate precursor to invasive breast cancer. And so many prevention strategies in the testing phase have utilized groups of women with ductal in situ. It is a prevention setting because DCIS in and of itself is not a threat to anyone's health, but the main reason for treating it is to prevent the occurrence of invasive cancer in the future. So DCIS treatment standards, just as a reminder, consist of surgery, sometimes used alone, but much more frequently used in combination with radiotherapy to the breast, and then with also the addition of tamoxifen, further improvement in outcomes. So radiation reduces the risk of invasive recurrence by about 1/2 in women with DCIS, and adding tamoxifen to that will then provide another 1/3 reduction in the risk of invasive cancer in the future. So this is the NSABP 2 trials pooled there, and then the UK ANZ trial, which tested the same idea in a different format, in a 2x2 design, but again, similar results, halving of the risk of invasive cancer with the addition of radiotherapy, and then a 1/3 reduction with the addition of tamoxifen. So despite this very, confident knowledge that in women with epithelial lesions in DCIS, endocrine therapy reduces the risk of new breast events by about 50%, the implementation of this has been very disappointing. Even these results were gathered about 10 years or so after more than 10 years after the publication of the P1 results. And this is data from the National Cancer Database. And you can see that even in women with ER-positive DCIS, just over 40% accept the use of endocrine therapy for risk reduction for the future. And data from SEER Medicare showing that among those who accept, the dark blue bars are tamoxifen, the light blue bars are invasive disease, early invasive disease. Even among women who accept, the adherence is really poor. So over the longer term, in this older population, only 1/4 will adhere to treatment. So although these are effective agents, proven in many large randomized trials, the implementation has lagged far behind, and the reason has largely to do with the reluctance of healthy women to take medication that might cause them ill effects. So then in trying to improve on this, it's useful to look at the fact that tamoxifen is a prodrug, in fact, and it's metabolized in the liver to 2 major metabolites. The one that was identified earlier in the 1980s was for hydroxytamoxifen, and then later on it became apparent that endoxifen, the other metabolite, is in fact possibly more important than for hydroxytamoxifen, but certainly is also very active in modulating the estrogen receptor. So 4-OHT is not bioavailable when delivered orally. So it was formulated into a transdermal gel by Pujol and colleagues in France in the 1980s. And they did a number of initial studies with this. And it finally worked its way into studies of mastalgia, where it was actually quite effective in reducing breast pain in women with benign mastalgia. But then it became apparent that once we know that this drug penetrates the skin, it may also be applicable to the breast cancer prevention paradigm. And here is the rationale for using drugs applied to the breast skin, local transdermal therapy, we call it, because when drugs are applied to the breast skin, they are retained largely in the breast. But one sort of background fact about this is that the breast is in fact a skin appendage. This has been known for a long time, and it is derived from the dermatomes of the thorax through a process of invagination of the epithelium. So in sentinel node studies, when sentinel node procedures became popular for breast cancer nodal staging, there were careful studies done of the anatomy of the lymphatic and venous circulation of the breast, and it became clear that there was in fact a well-developed internal circulation in the breast with both lymph channels and venous channels taking material from the surface to the deep aspects of the breast and to the lymph nodes. And then a series of studies showed that drugs applied to the breast skin reach higher concentrations in the breast than if those are applied elsewhere on the skin in other parts of the body. So this needed to be demonstrated because we use transdermal delivery frequently for systemic therapy. Nitroglycerin obviously is a very early example, but there are many others. And this concept is in fact not for systemic delivery, it's for local delivery. And then the other part of this story is that the systemic exposure then is very low, and concentrations in the circulation when drugs are applied to the breast skin are in fact anywhere between a fifth to a tenth of what they would be if the drug were taken orally. So there is evidence of efficacy of transdermal delivery through the breast skin. This was an earlier study published in 2005, again by a French group, and they did what's called a window trial. So in the pre-surgical window between surgical consultation and surgery is an opportunity to test drugs where you can get tissue from the diagnostic biopsy of the lesion, as well as the surgical resection of the lesion, and the interval between them, drugs can be tested. So window of opportunity trials, or window trials in short. So this was a window trial, and here you can see the results of decreasing cell proliferation in women who were given oral tamoxifen. That was the positive control group, and then they were randomized additionally to 3 different doses of this 4-OHT gel. This was the highest dose group, 1 milligram per breast applied daily, and the decline in Ki-67 was essentially equivalent to the decline seen in the oral tamoxifen group. And then they also looked at drug concentrations. These are concentrations in the breast, so you can see an increase, a dose-dependent increase in the breast tissue concentration, which is very clear, but the concentrations in the plasma were much lower. So that's the basis of what I said earlier, that systemic exposure is low with this type of delivery. So we conducted a trial in women with DCIS with the idea that invasive cancer is really not the right setting for the use of this delivery formula, this approach to delivery, because for invasive cancer, systemic therapy actually is required. So decreasing systemic exposure is not a good thing for women with invasive cancer, but decreasing it for women with DCIS and those who are at high risk and need preventive medication would actually be quite advantageous. So we designed this trial that was funded by the Division of Cancer Prevention, and it was published a few years ago now, where we enrolled women with ER-positive DCIS diagnosed by core needle biopsy, and they were stratified by menopausal status and randomized to either the gel with oral placebo or the oral form with gel placebo. And the idea was that we would compare again the diagnostic core needle biopsy to the surgical sample. We planned to accrue 100 women, but had to stop at about 28 or so because the manufacturer decided to devote their resources to a different project and stopped making the gel available. So we did analyze the results from that small study though, and found similar results to those described by the French group, in that oral tamoxifen caused a significant decline in Ki-67 labeling, or that's the proliferation marker that we use. And the gel group demonstrated a similar decline with no statistical difference in the slopes between the two. So, so this was taken as very preliminary evidence of equivalence and led to the subsequent trial that I will discuss in a little bit. And then the other part that we looked at in this study, which was also encouraging, was that there are some known consequences of oral tamoxifen on circulating proteins. So IGF-1, insulin-like growth factor 1, and SHBG, sex hormone binding globulin, those are both markers of estrogenicity. So when there is estrogenic exposure, these two are expected. IGF-1 is expected to go down and SHBG is expected to go up. That's what happened with oral tamoxifen exposure. And then the second set of four proteins is coagulation proteins that also are known to change with oral tamoxifen use. So we found the expected changes that were significant in the oral tamoxifen group, but none of these changes were significant in the 4-OHT gel group. So substantiating the idea that the systemic exposure is low enough that it should not cause complications, adverse effects like, for instance, thromboembolic problems. We also measured the concentration of the metabolite that we were delivering through the skin, the 4-OHT, and we found that in the plasma, there was much less 4-OHT in the circulation than with oral tamoxifen. But when we measured the breast concentrations, the 4-OHT was similar in the oral and the gel group. Sorry, this is Z and this is E. These are two isoforms of 4-OHT. The blue is the oral group. And so there was 4-OHT at similar concentrations. There was some endoxifen, which is the other metabolite in the oral group, which was to be expected, and there was none in the gel group, which was also to be expected. But because we saw similar declines in Ki-67, it seemed that perhaps that endoxifen exposure was not so important in achieving reduction in proliferation. So the conclusion from this study then was that 4-OHT delivered to the breast skin penetrates into the breast. The adipose levels are equivalent to those achieved with oral tamoxifen. The circulating levels are low. The decrease in proliferation of DCIS cells is equivalent. And the effect on circulating markers and the coagulation cascade are small. So all of this was very encouraging, and we wanted to, continue with this direction of investigation. But the gel that we had been using was not available at the time. So the questions that immediately came up in considering those results and thinking about next steps were related to the pharmacokinetics. So do these drugs reach deep within the breast? Is the distribution uniform? Is daily dosing necessary? And can novel methods improve drug permeation and delivery? So we tried to address each of these. I don't really have time today to go into these in detail, but I will show you some data addressing some of these, and then obviously continued investigations necessary to address others. But because the 4-HT gel was not available, we turned to a different drug, Telapristone acetate, which is a progesterone receptor antagonist. And in fact, we had reasons from other work in the lab suggesting that perhaps progesterone antagonists would be very good and breast cancer risk reduction agents, breast cancer prevention. So Oksab Lee, who is research assistant professor in my group, and is interested in this area and has actually done a tremendous amount of work and deserves a lot of credit for what I'm presenting today. She formulated this Telapristone topical formulation with using a chemical permeation enhancer, oleic acid, and this was an in vitro experiment using standard system of looking at human skin permeation using shaved skin. And showed that this drug actually does penetrate the skin and should be tested further. And compared the permeation to that of estradiol in the system and found that it was similar. So it had promising characteristics in terms of further investigation. So, so we designed this trial because it was a PK trial. We really wanted multiple samples from the breast in order to look at the distribution through the breast. And so we enrolled women who were undergoing mastectomy for either therapy or prevention. And it was a multi-center trial, including investigators at Cedars in LA and Memorial Sloan Kettering in New York. Melissa is actually one of our former residents. She graduated from general surgery here at Northwestern. So this was our protocol for assessing drug distribution within the breast. We took multiple samples from different portions of the breast, about 6 in total. And because these agents that penetrate the skin tend to be lipophilic, and Telapristone is known to be lipophilic, in fact, with a high affinity for fat, we wanted to look at the concentration relative to the fattiness of the tissue that was being examined, because the breast, as you know, is a very heterogeneous organ. Even within the same woman, different parts of the breast will have different fractions of adipose tissue. And then between women, obviously, there's heterogeneity. So we collaborated with the group at UNC, Chapel Hill, and they had this system of digital evaluation of sections to quantitate the relative fractions of fat and epithelium and stroma. And here you see examples. We split our drug sample into 2. We sent one for H&E, and then that H&E section was sent to North Carolina, where they generated these data telling us about the adiposity of the tissue. So what we found with this Telapristone formulation was that, in fact, it did not penetrate the skin as well as we had hoped. The drug concentrations in the gel group were in fact lower than in the oral group, but the interesting thing that came out of this study, which almost made it worthwhile and sort of decreased our disappointment in the permeation results, was the data on distribution. So as I said, we measured distribution at multiple locations in the breast. And this is the most superficial location, and it had the highest concentration. But this central deepest is this location, deep in the breast, and the thickest portion of the breast. So that location number 2 had the second highest concentration, and then the others were variable, but the variation was parallel between the oral and the gel groups. So, you know, one expected the gel group to be somewhat variable. It was somewhat unexpected that the oral group would have the same kind of variability. And this was, in fact, new data because no one had actually looked at the variation in distribution within the breast previously. So this was a little bit surprising. but it also supported the idea that perhaps the concentration at a single time point is not all that important, and that the breast adipose tissue actually functions as a reservoir and leaks drug slowly into the breast, which is why these endocrine agents that presumably also have some variation in their distribution are effective, even though the distribution within the breast may be variable. So, so this is what we learned about drug distribution within the breast, which was encouraging. And this is just showing you that the variation was very similar, another way of looking at the same data. But the message basically is that there was excellent correlation between the two locations, between the locations in the breast and the rank of where the drug concentration was in both oral and gel groups. So what we learned from this was that drug concentrations are variable, but similar to when delivered transdermally to those seen with oral delivery. For lipophilic drugs, the adipose fraction of the breast is richest in drug content. Non-lipophilic drugs may have different distribution characteristics, and those will probably need to be studied. And that the drug is available to the epithelium from the adipose reservoir and is biologically active. And the evidence for that came from the 4OHT, because we didn't measure the distribution in the 4OHT study, but we saw biologic efficacy. So if the variability was similar, then the biologic efficacy was still there. So then we had another little side journey that I'm not going to get into now, but the 4OHT gel became available again. So as a result of that, we had a second study funded, which was essentially a continuation of the first study, just to demonstrate in a larger number of women that this model that we tested is in fact valid, and that the results in the oral and the gel group in terms of a decline in cell proliferation in the DCIS lesion are similar. So this was sort of looking for similarity in the change in cell proliferation. And then, you know, because of the interest that these results had generated, there were several other studies that were launched a little bit later than this study that I'm going to talk about in additional detail, because this was done at, you know, this was initiated at Northwestern. But in addition, there is a study that has completed accrual at MD Anderson, which was again a multi-center study, and we did collaborate on that. We did accrue quite a number of patients to that study, and that is looking at breast density. So breast density is considered to be a surrogate endpoint for breast cancer risk reduction. If the density declines, the expectation is that the risk will also decline. And obviously, there's also the other benefit of declining breast density in that the mammographic sensitivity improves. As we all know, with dense breast, mammographic sensitivity is poor, but if we can make them less dense, the sensitivity is expected to increase. So that is the second study looking at breast density. And then at the Mayo Clinic, Amy Degnam, who's the surgeon, has an R01 to look at a similar sort of design to our DCIS study, but now looking at women with atypical hyperplasia and LCIS, otherwise very similar with similar questions. And then finally, we have an R01 funded study at Northwestern where we're looking at the inter-individual variation of permeation. So we're measuring drug concentrations in the breast tissue of about 100 women with the specific goal of assessing variation and relating it to skin structure. So we're looking at breast skin punch biopsies, but also using a laser sort of a virtual biopsy using a confocal microscopy, which is a dermatology technique. So we don't have results on that, and I won't get into it. But these are the various aspects of transdermal delivery that are being looked at the moment. using this particular formulation as a model. So what we expect to learn from these studies is for the two efficacy studies, we will verify the efficacy of 4-OHD gel for Ki-67 reduction. Also for atypical hyperplasia and LCIS, similar approach. And then for the density study, we'll also gain information about compliance. So these two studies on the left are both short interval studies. They're both being done so our study was at Northwestern was 4 to 10 weeks. The Mayo Clinic study is also a similar short interval of treatment. The breast density is a whole year of treatment. So we'll get data about whether women adhere to applying a gel to the breast every day for a whole year. And then, of course, this inter-individual variation we will learn about, but I didn't mention we are enrolling women who have a history of radiation on one side. So these are breast cancer survivors who've been radiated on the affected side and then have an unaffected, unradiated breast. And we are studying both breasts. So within the same person, we will get an idea of the effect of radiation on permeation of the drug. So to get back to our DCIS study, this is the only a small portion of the number of people involved, but this is Oksabli, whom I mentioned. This is Brandy Heckman-Stoddard. She's the program manager at DCP and has been a tremendous colleague and collaborator and program person for us to deal with, tremendously supportive of this whole avenue of investigation. And these are other, our medical monitor and the nurse clinician who's involved. And this person, Yan Fei Shu, is so instrumental in the success of this trial in terms of running it, conducting it, accruing to it, helping with the analysis and so on. So that's only a handful of all the people who worked on this. So again, the idea was that we wanted to show that 4-OHD gel penetrates the skin and has an equivalent reduction. So this is an example on the left of Ki-67 positive cells in a DCIS lesion. That's what we were measuring and quantitating. And we wanted to show that it's non-inferior. Secondary objectives were to get additional data on drug concentration by location in the breast, as we did for the Telapristone study. And then we also wanted to look at this DCIS score. So this is a derivative of the Oncotype DX recurrence score, which has been developed and has been around for breast cancer management for about 2 decades now. It's 15 gene panel, actually 21 genes, but 15 of them are specific to breast cancer biology. The rest are housekeeping genes to assess whether a woman will have sufficient benefit with tamoxifen or will also need chemotherapy. So that's for invasive cancer. So the DCIS score is derived from that, and it is for women with DCIS. And we wanted to see if the tamoxifen responsiveness that we would measure with Ki-67 decline would also be reflected in the DCIS score. So this is just the blue boxes show you the progress of the study, but this is just to show that 1,232 women were screened for eligibility, at least the preliminary screening. And so we usually calculate that we will be able to enroll 10% of eligible women. And I was really surprised that it turned out to be exactly that. So that's nice data to have, because usually that number screened is not monitored very carefully. But this is what we do with the DCP. We have tools for this. At any rate, 107 were randomized, 100 started agent. There were dropouts at various levels. And then finally, we lost about 8 in this group and 7 in this group. 15 out of 100 were lost for the primary endpoint evaluation because there was no residual DCIS in the surgical sample. And that happens about 15% of the time. So it was not terribly surprising. And finally, we had 39 in the oral group and 33 in the gel group for analysis. These are their demographics, pretty well balanced. But the other thing that we had to measure in this particular study was bra cup size. It was actually an important point in sort of documenting the variation of drug concentrations in the breast. Everyone always asked, what about breast size? Can you use the same dose for a large breast as you do for a small breast? So we have data on cup size. These are the data at study entry, the DCIS features. So we required a minimum size of the DCIS on the core needle biopsy so that we would have enough tissue to assess the Ki-67. The nuclear grade, there were very few low-grade DCIS. They were mostly either high or intermediate grade. And then at surgery, we had a good size of DCIS and a median of 25 millimeters. There was a little imbalance in the surgical procedures, so there were more women who had breast conservation in the gel group, but this was not a stratification point in the full trial, so not surprising. And then they were all ER positive by definition for entry into the trial, and the majority were also progesterone receptor positive. So our non-inferiority boundary was set at, we expected that there would be a decline of 50% in the oral group, and if the decline in the gel group was 35%, we would accept that as evidence of non-inferiority. So here you see the results. So the average absolute decline was minus 4.5% in the oral group. It was minus 1% in the gel group. Clearly not what we wanted to see. And we actually are still sort of exploring the data and trying to explain it, because one of the possibilities in a small randomized trial is that there are imbalances in the things that we didn't stratify for. So there are other parameters that are still being measured, but the primary endpoint results might be explainable, but they likely won't change to the point where we will consider this to be evidence of non-inferiority. I don't think we'll get there. The DCIS score changed very substantially in the oral tamoxifen group, not so much in the gel group. So that sort of is in the same direction as the Ki-67 results. And so, you know, is evidence of inferiority of the gel group, at least as far as we can tell at the moment. This is the spaghetti plot that we always like to look at, and it's nice because it shows us patterns. So you can see that in the gel group, there would be these patients. So that's why I think that there is the possibility of some difference in the biology of the DCIS lesions that by chance happen to be randomized here compared to here. But obviously that's something we need to generate the data for, and we are looking at the other markers that I mentioned. So we did stratify by menopause, and these are the results by menopausal status. So in premenopausal women, the difference was not so big in the gel and the oral group, but in postmenopausal women, there was a clear difference. So postmenopause, gel, and oral and gel. The gel is always coral. So drug concentrations, we did see somewhat the same story as with Telapristone. The superficial location was much more variable. Here we are showing two locations because they were measured in all the participants in the study. And so it was more variable in the superficial location, but the deep location had less variability and had essentially the same concentration as in the superficial location. At least the median was very similar. So the median in the superficial location was 3.9 nanograms, in the deep location was 3.7 nanograms. The oral group had larger amounts of 4-OHT in both locations. but the big difference is here in the endoxifen. So this is the endoxifen concentrations, and they were clearly much higher than what we had seen previously. And this might be a matter of measurement. We did change labs in terms of the drug concentration measurement. We're working now with the group in Norway, and this is they provide this as a core service, but it is also a matter of intense interest in research for them. So a very highly qualified group, and I think that this endoxifen measurement probably reflects reality measured in this current trial compared to the older one. Plus that trial was really small and this one is much larger. So in looking at drug concentrations and whether they explain the difference in the Ki-67 decline, you can see here that this is the oral group, this is the gel group, and this is 5 nanograms. The vertical line is 5 nanograms. So the drug concentration in the deep location in the gel group was 4, in the oral group was 6. So this is the midpoint between the 4 and the 6 medians, and this is the 0 change for the Ki-67. So in this space where we would have wanted to see all of the data, we're seeing clearly more oral data than gel data. The gel data, when it's to the left of the 5 nanogram line, there's quite a bit with Ki-67s that went in the wrong direction, that went up rather than down. When we then look at the absolute concentration and exclude and separate out the women in the gel group who had a concentration in the lowest quartile, which is less than 1.5 nanograms, we do see a significant decline here, but I didn't post the p-value because obviously that's very exploratory. So anyway, we cannot explain these results totally on drug concentration. When we add in the endoxifen, we see again in the oral group, there were many that had a good amount of endoxifen in the tissue, and all of the data points are below the 0 change line, so all showed a decline. So I think the big message here is that it's a little bit actually like the beta carotene study. So among the epidemiologists who are listening, there's you're I'm sure aware of all the tremendous work that went into explaining the results of the carrot trial, and it all had to do with I think that the fact that you cannot take a single element out of a complex food or a complex group of a complex supplement and expect it to have a specific change. So here we're dealing with drug metabolites, and we have 2 major metabolites. If we put only one of them in a gel, it's, we see not going to do the job that we expected it to do. So this is a cup size data just for interest, and we don't see any clear pattern with cup size. So in the future, we may try a larger dose with larger breast size, but I don't think that's where the explanation is in this study. Multivariable model, we looked at multiple variables in the beginning, but dropped sequentially days, then menopausal status, then bra cup size, then grade. And I left this concentration on here just because that's sort of the obvious explanation, and you can see that it's not significant. What's significant is the group. So we have looked at endoxifen, and I will not talk about those results. I'm pretty much out of time. And we were planning a phase 3 trial. There was a lot of excitement that this phase 2 trial that we just finished would lead to a phase 3 trial. And this was the design. I won't get into the details of it, but obviously it's back to the drawing board. And then I was going to talk about this other approach, and I will just mention it in 30 seconds because I want to leave some time for questions. But our competitors in this field of improving the tolerability of tamoxifen is a group in Italy, Andre Dicenzi and colleagues who have been working on this idea for a long time, that you have to reduce the dose that you use in prevention. So they took this bold step of cutting the dose of tamoxifen to 1/4 of the standard dose compared to placebo in a small study. And I will just show you the results, which are here, that they saw a reduction. This hazard ratio is 0.5. They saw a reduction in subsequent events. So this was a 5-year follow-up study. So the endpoint was the occurrence of new breast events, either DCIS or invasive cancer. And the magnitude of the reduction was similar in this study with 1/4 of the dose of tamoxifen as it was in the very large study. Now, obviously, the confidence is nowhere near what we saw in the large study, but this is very provocative data, and it's going to lead to, I think, a lot of additional investigation about this particular agent at lower doses, but also lower doses for other agents. So I will actually stop. Well, I should go to my acknowledgement slide because that's important. So I mentioned Oksab, Kelly, and Jan Fei. Kelly is the manager of the Cancer Center, the clinical trials for cancer prevention network at Northwestern. We are the LAO, and Kelly is our manager. Jan Fei, I mentioned already. Louise is the pathologist working on the study, along with people at Demir and Shan at the pathology core facility, and of course our invaluable statistical colleagues, the University of Bergen, very valuable contribution, and then our partners at NCI. So I will stop sharing and see if we can take a few questions.
Well, Seema, that was a fantastic presentation. I learned so much. Just congratulations on all your wonderful work. It's really incredible. So I don't see, please feel free to put questions into the question answer. I'll ask a question. So are there any thoughts at looking at other drug delivery mechanisms, perhaps that would allow for kind of more sustained long-term delivery in cancer prevention?
So topical, actually, so local delivery is an area of great interest. So we had a trial of inhaled iloprost, which is, intercepts the cyclooxygenase pathway, and then there are agents that are retained in the gut, so are not absorbed, but are retained in the gut. These are all very early phase studies. And then recently, I heard a talk at our recent prevention symposium that's organized at NCI of an inhaled microRNA for lung cancer prevention. And then a topical application in the oral cavity for leukoplakia and oral cancer prevention. In the breast, the other approaches that are in very early phases. So we are now switching gears. Actually, the next step for us will be to look at nanoformulations, because there are many nanoparticles, particularly liposomes of various types, that have been used to improve transdermal permeation, and that will be. We're working with the company now to try to generate nanoformulations of transdermal delivery, because they should provide much better penetration and higher concentrations in the breast. There is a group in San Francisco at UCSF who has been working in a preclinical model. I don't think they've done this in a clinical trial as yet, but using the kind of silastic catheters that were used for depot formulations of contraceptives, using those for insertion into the retromammary space. So it would be a small incision, and this elastic tubing would be inserted into the retromammary space. And they have preclinical data. I don't think it's gone beyond rodents yet, but they have preclinical data that they generate a good concentration in the mammary tissue. And so that would be another way of delivering drugs locally. There are lots of nanofilms that have been developed, and reservoirs in the breast. The problem always is that, are they going to interfere with imaging? How often do they have to be replaced? Things like that.
Great, thanks. Sounds like there's a lot of work being done by a lot of groups. Well, it looks like it's 1 o'clock on the nose, so just check the Q&A again. It doesn't look like we have any other questions. I want to thank you so much on behalf of the Medical Faculty Council for accepting our invitation to speak today. That was truly a wonderful presentation. Thank you.
Thank you very much for the invitation. I enjoyed thinking about this from a slightly different perspective. So
great, thank you.
Bye-bye.
Bye.